Dr. James Amos. I'm a consulting psychiatrist at the University of Iowa Hospitals and Clinics in Iowa City, Iowa. And this is another geezer video. It's the Dirty Dozen on factitious disorder and malingering. And it goes with a blog post on the Practical Psychosomaticist at URL jajsamos.wordpress.com. And I've done a couple of these, and I like doing them because they're short and pithy, and they get the general idea across relatively quickly. I have copies of the slides here that I'm going to go through so as I can stay on track. And you can follow along. If you're seeing this on YouTube, you can go to the Practical Psychosomaticist and see the video there, and see the slides and annotations. There's also a short quiz. We'll start with slide 3, and it's a slide about the diagnosis per the Diagnostic and Statistical Manual. And the diagnosis of factitious disorder is intentional production or feigning of physical or psychological signs or symptoms. So this can be a disorder in which depression, alcoholism, schizophrenia, and bipolar disorder are all lied about and faked. Physical problems are limited only by the imagination of the patient and have run the gamut from infections, fevers, and other types of medical problems that can be manufactured. Now, the patients deliberately produce these symptoms or lie about them. The motivation for the behavior is then presumed to be to assume the patient role. And also external incentives for the behavior, such as economic gain, avoiding legal responsibility, or improving physical well-being, are all absent. Malingering is more of an accusation than a psychiatric disorder. In fact, it's not a psychiatric disorder per the DSM. It is the deliberate production of feigned illness, but it's motivated by external incentives, which differentiates it from factitious disorder. And usually the incentives are things like entitlements or evading criminal prosecution or avoiding military service, things like that. You should suspect malingering when there are obvious external incentives, concurrent antisocial personality disorder, or marked discrepancy between claimed symptoms and objective findings. There's usually poor cooperation with evaluation and treatment. And slide 4 is about historical notes. And Munchausen syndrome as a term was first coined by Dr. Richard Asher and published in the 1951 issue of The Lancet. And it described a severe form of factitious disorder, and we still call the most severe form of factitious disorder Munchausen syndrome today, and it occurs in about 10% of this group of patients. And the patient adopts this role sort of as a career. The first published Iowa case report of Munchausen syndrome was in 1957 in the Journal of American Medical Association by Dr. John Chapman, and the title of it was Peregrinating Problem Patients, Munchausen Syndrome. And it was about a particular individual known as the Indiana Cyclone. The Indiana Cyclone was also immortalized in a poem called the Munchausen Saga, written by another Iowa physician named Dr. William Bean, and he was head of the Department of Internal Medicine here decades ago. And I just would like to read to you the first stanza of the poem, the Munchausen Saga by Dr. Bean. The Munchausen Saga starts this way. In the summer of 1954, at Iowa City to our hospital door, Mecca for hundreds every day, a merchant seaman found his way, a part-time wrestler in denim jacket. He crashed through the door with a horrible racket, 260 pounds at least, and covered with blood like a wounded beast. The Indiana Cyclone was a real person, and the poem goes on for many pages about his colorful exploits, most of which were lies. And he underwent excruciating painful procedures, which most malingerers would usually avoid. Now, this selection of the stanza of, or the first stanza of the Munchausen Saga is taken from my chapter called Managing Factitious Disorder and Malingering in the book co-edited by Dr. Bob Robinson and myself, The title is Psychosomatic Medicine, An Introduction to Consultation Liaison Psychiatry, and it looks like that. Might as well plug my book since this is my video. In 1994, the factitious disorder by proxy was introduced into the DSM-4 and is defined as the deliberate production or feigning of physical or psychological signs or symptoms in another person who is under the individual's care. And children, unfortunately, are often the victims. The diagnosis is not applied to the victim, but to the perpetrator. A quick literature review turns out that there's really no evidence-based literature in terms of controlled trials about factitious disorder, although there were about 1,900 papers published from 1985 to the present. Most of those are case reports. There are 2 meta-analyses, 8 reviews, and many case reports. Of course, as already mentioned, the comments on the reviews that are probably useful are that early detection will likely prevent chronic illnesses. A therapeutic approach is emphasized with psychiatrists and primary care physicians collaborating, and the primary care physician should strive to adopt a conservative medical management approach in order to avoid causing further harm to the patient. The development of a therapeutic alliance is essential for treatment. Of course, we'd all agree about that, but it's very difficult to establish a therapeutic alliance when the patient has no trust in the medical profession, yet perseveres at trying to fool the medical profession. Demographics tend to show that overwhelmingly patients are young, educated, white, female healthcare workers. And fortunately, a systematic review of treatment thus far found no robust evidence supporting any management strategy, which is not to imply that there's no hope. What we probably need to focus on is demonstrating to this patient population that we would like to establish a trusting therapeutic relationship so that we can help them stop hurting themselves. Factitious disorder with physical symptoms, a retrospective examination, is a paper written by Lois Cron and others and published in 2003 in the American Journal of Psychiatry. And after a 21-year review of 93 patients, the mean age of this group was about 31, 72% were female, 90% Caucasian, almost 70% were employed, 20% left the hospital against medical advice, but approximately 20% agreed to psychiatric treatment, which is a sign of hope. A very interesting idea is factitious Munchausen syndrome, which was the subject of a case report published in 1980 in the New England Journal of Medicine, and it was a report written by emergency room resident physicians about a man named Norman U. Senchbaum. Norman is spelled N-O-R-M-A-N, U is the middle initial, Senchbaum is S-E-N-C-H-B-A-U, and of course this is an anagram for Baron Munchausen, and the whole case report is a sham, it's a hoax. In fact, it's a lie. Now it's impossible to publish such case reports in the New England Journal of Medicine or any other peer-reviewed journal of this nature. But the interesting points about the case report really got at the paradox that factitious disorder encompasses. So the patient who is fictitious actually lied about having visited many hospitals and habitually mimicked medical conditions and demanded immediate hospitalization for treatment of his Munchausen syndrome. He lied about having many surgeries and displayed a gridiron abdomen. Gridiron means many surgical scars, washed off with soap and water. He lied about being treated with chemotherapy for cancer and electroconvulsive therapy for depression. He called the many hospitals he listed, and nobody had ever heard of him. And he left against medical advice when he was confronted with his inconsistencies. Now, of course, the whole story was made up, but many authors actually cited this case report and reports afterward. The authors left a clue. I mean, they did identify the patient more or less as Baron Munchausen, if you could figure out the anagram. But Mark Feldman, a nationally recognized expert in factitious disorder, actually wrote a paper exposing this hoax, and the two authors of the paper later admitted it. Factitious disorder in the 21st century is slide 8, and it's about the increasing availability of computer-based medical records and the hope that it will facilitate communication between institutions and may help early recognition and diagnosis of this group of patients. And it's also hope that this will foster the understanding that this is an illness that often starts in childhood, and that early intervention and detection can prevent chronicity of the illness. Slide 9 is about factitious disorder on the internet. More than 14 cases have been described, and the terms virtual factitious disorder and Munchausen by internet have been coined by Mark Feldman, identified earlier as an expert on factitious disorder. People who engage in this tend to jump from one online support group to another and identify themselves as the patient, son, or mother of somebody with factitious disorder to make the story seem even more convincing. Conclusions and new directions is slide 10, and at a 2007 annual psychosomatic medicine meeting, Dr. Lois Cron and others proposed that the DSM-5 place factitious disorder within the somatoform disorder category, and in a term, somatoform disorder with factitious behavior. They also agreed with continuing to use lying as well as self-production of illness or self-harm as diagnostic criteria. There's also a proposal to consider placing factitious disorder in the category of access to personality disorders, because they tend to be intractable, inflexible, enduring, pervasive maladaptive behaviors that deviate markedly from cultural expectations. They're stable over time. They lead to a lot of subjective distress and functional role impairment, and they begin in early adulthood. Management guidelines exist, and they're common sense and practical. The best goal is to stick to interventions that are indicated by objective signs rather than the subjective report of the patient. Tends to lie to doctors. Setting compassionate but firm limits on requested interventions is also wise to avoid further harm. And team members should communicate with each other in order to avoid splitting. Slide 12, of course, is a list of references, which is more extensive on the blog site within the post. And I hope this has been helpful, and that you'll have some comments or questions for me about it. Really thank you for listening, and I welcome you to the Practical Psychosomaticist. And this is yet another Dirty Dozen. Oh, look at the time. I have to go to work.